Hello and welcome. I'm Fernando, a GP in the UK. Today we're doing a review of the NICE guideline on CKD or NG203, focusing on what is relevant in primary care only. Given how extensive the guidance is, in this episode I will just focus on investigations, monitoring, referral recommendations, and blood pressure management in CKD. If you haven't already, I recommend checking out the previous episode on diagnosis and classification of CKD. In the next episode, I will cover the rest CKD management in primary care, including renal anemia and mineral bone disease in CKD, so stay tuned for that. Right, let's jump into it. And let's remember that for this review, I have excluded recommendations related to children and young people with CKD. While their management is often similar to that of adults, most children with CKD are managed by secondary care, which is why I am focusing on adults only. We will offer a renal ultrasound in CKD if there is visible or persistent invisible hematuria, suspicion of urinary tract obstruction, a family history of polycystic kidney disease for those older than 20, a GFR of less than 30, if there's a need for renal biopsy, and accelerated progression of CKD. We will define accelerated progression of CKD as a sustained decrease in eGFR of 25% or more, and a change in GFR category within 12 months, or a sustained decrease in eGFR of 15 per year. These people are at high risk of progression to end-stage renal disease. If we're worried and we want to identify the rate of progression of CKD, we will obtain a minimum of 3 eGFRs over no fewer than 90 days. And if we see a low eGFR for the first time, we will repeat the eGFR within 2 weeks to exclude acute deterioration, for example, an acute kidney injury or secondary to starting treatment with, for example, ACE inhibitors and ARBs. Although CKD is not progressive in many people, we should monitor CKD regularly, and the frequency will depend on the stage. It will be once a year when the risk is low, for example, categories G1 and G2, and up to 4 times a year or more when the risk is very high, for example, category G5. For G3A, G3B, and G4, the frequency of monitoring will depend on the ACR level. There is a table showing the frequency of monitoring depending on the CKD classification, which you can find in the episode description. Monitoring should be tailored according to the underlying cause, the rate of decline in eGFR or increase in ACR, other risk factors including heart failure, diabetes, and hypertension, changes to the treatment such as ACE inhibitors, ARBs, non-steroidal anti-inflammatory drugs and diuretics, and intercurrent illness, for example, acute kidney injury. Risk factors for CKD progression are cardiovascular disease, proteinuria, previous episode of acute kidney injury, hypertension, diabetes, smoking, African, Caribbean or Asian family origin, untreated urinary outflow obstruction, and chronic use of non-steroidal anti-inflammatory drugs. And let's remember that in CKD, the chronic use of non-steroidal anti-inflammatory drugs may be associated with progression, and acute use is associated with a reversible decrease in eGFR, so we should exercise caution when prescribing them. When it comes to patient education, we will give lifestyle and dietary advice, including guidance on potassium, phosphate, calorie and salt intake. However, we will not offer low-protein diets. We should give patients information about their 5-year risk of needing renal replacement therapy. For this, there is a 4-variable kidney failure risk equation. You'll find a link to the calculator in the episode description. We will refer for specialist assessment if they have a 5-year risk of needing renal replacement therapy greater than 5%, an ACR of 70 or more unless caused by diabetes and already treated, an ACR of more than 30 with hematuria, poorly controlled hypertension despite 4 antihypertensive medicines, known or suspected rare or genetic causes of CKD, suspected renal artery stenosis, and accelerated progression of CKD. Additionally, we will refer people with CKD and renal outflow obstruction to urological services. In respect of blood pressure control in CKD, if ACR is under 70, we will aim for a clinic blood pressure below 140/90. However, if ACR is 70 or more, we will go for a lower clinic blood pressure below 130/80. If someone has hypertension and CKD with ACR of 30 or less, we will simply follow the NICE guideline on hypertension. The link to the corresponding episode on this channel is in the episode description. However, for those with hypertension and CKD with an ACR over 30, we will offer an ACE inhibitor or an ARB in the first instance, and we will titrate it to the highest licensed tolerated dose. If they also have diabetes, we will lower this threshold to an ACR of 3 or more. And, as we know, the combination of ACE inhibitors and ARBs are not recommended. We will measure potassium and eGFR before starting an ACE inhibitor or ARB and between 1 and 2 weeks after starting treatment and after each dose increase. More frequent monitoring may be needed if they are already taking medicines known to promote hyperkalemia. We will not routinely offer an ACE inhibitor or ARB if their pre-treatment potassium is greater than 5. In these cases, we will assess and treat any factors that promote hyperkalemia, and we will check the potassium again. We will stop ARBs and ACE inhibitors if the potassium level increases to 6 or more, and other medicines known to promote hyperkalemia have been discontinued. There is separate guidance on the management of hyperkalemia, and a link to it is in the episode description. Because their mode of action, ARBs and ACE inhibitors can reduce the eGFR and increase their creatinine levels. However, after starting or increasing the dose, we will not modify the dose if either the eGFR drop is less than 25% or the serum creatinine increase is less than 30%. In these cases, we will repeat the test 1 to 2 weeks later, and we will not change anything if the decrease in eGFR remains less than 25% or the increase in creatinine remains less than 30%. Why this advice? Let's remember a bit of anatomy. The glomerulus receives its blood supply from an afferent arteriole, and unlike most capillary beds, the glomerular capillaries exit into efferent arterioles rather than venules. Let's also remind ourselves that ACE inhibitors prevent the conversion of angiotensin 1 to angiotensin 2, and ARBs block the effect of angiotensin 2. This results in relative vasodilation, which preferentially reduces postglomerular resistance. Consequently, this will lower intraglomerular pressure, which will reduce the glomerular filtration rate and cause a subsequent rise in creatinine. So, as stated before, an increase in creatinine of up to 30% and a decrease of eGFR of up to 25% are acceptable, and in the absence of renovascular disease, creatinine levels will frequently return to baseline or below if blood pressure is lowered, even despite the continued use of an ACE inhibitor or ARB. However, if the eGFR decrease is 25% or more, or the increase in creatinine is 30% or more, we will investigate other causes such as volume depletion or concurrent medication, for example, non-steroidal anti-inflammatory drugs. And if no other cause is found, we will stop the ACE inhibitor or ARB, or reduce the dose to a previously tolerated lower dose, adding an alternative antihypertensive medication if needed. So that is it, a review of monitoring, referral recommendations and blood pressure management in CKD. We have come to the end of this episode. Remember that this is not medical advice, but only my summary and my interpretation of the guidelines. You must always use your clinical judgment. Thank you for listening, and goodbye.